So good morning. This is MED110 5DAX Tuesday morning, 9 a.m., June 29, week 6. Just as a quick reminder, week 8, 9, and 10 are on campus. If you cannot make it, I need to go, and I'll be putting another reminder. There's also another nice reminder here. Did I put it in here? We have a Inova Employer Spotlight. It's for people who are, even if you not working in the healthcare field and would like to break into the healthcare field, which is highly advisable, because going into a healthcare program without having any prior experience, how do you know you want to do the job if you've never really done the job, or haven't really experienced healthcare? And it's also for there's for experienced people who want to get into a bigger facility like Inova, and it's wonderful. My wife works for Inova, and I am seriously considering applying to Inova. They have comparable benefits, and they're very, very nice things, and it's nice working for the bigger, better deal. They're also, and so watch out your emails and watch out your announcements, because not only employer spotlights, sometimes I highlight things that are going on in the industry that only the insiders know. My current job here at Stratford, I also have positions at George Mason and George Washington. None of these positions were advertised. They're all word of mouth. They're all people in the business. So if you have, and especially if you don't have a LinkedIn, and if you're not active on your LinkedIn, woe is you. You're not maximizing your your professional and money making capability. We have a question, Ms. Jallo.
Yes, sir. Concerning this Inova, what qualification they need?
They didn't say. It's just an employer spotlight, and usually they invite somebody from human resources. And it was the same thing for my wife's position. She's a healthcare administrator at Inova, and they just said, "Hey, bring your resume, bring any questions you want, listen to their presentation," and they do this on every university and various facilities, because Inova is growing exponentially, and also they have a high standard, so they keep on firing people.
Wow.
Just like nursing, if you don't make the grade, they just get rid of you. Remember, this is Virginia. It's an at-will state. If you do not perform, the real world is not as forgiving as the academic world. The standard is the standard is the standard. That's why I have a upcoming meeting with School of Nursing, because they're complaining that the incoming nurses can't handle things academically. And that brings me to my next topic. Across the board, there has been a decrease in midterm and final scores, less than 10%. And a whole bunch of you are failing the T's. Now, you got to think about it. You guys are only supposed to you're only supposed to focus on one part of the T's. There are a whole bunch of nursing schools that they want the whole score. They're not looking for just a partial score. They're looking for the whole thing. So please be aware that the profession that you have chosen is quite a strict one, because when you think about it, you're in charge of people's healthcare. And I've always said this, especially at new student orientation. With no due disrespect to any other school, like for example, culinary or business, you mess up in business, what's the worst can happen? You mess up with us, you either hurt or kill people. And that's a serious thing. Therefore, it requires a serious standard. So whatever standard you believe you're living up to, raise the bar, please. But you will also notice that for this particular term, your midterm and your final is only 10%. So if you're doing your due diligence all this entire time, there's several of you who are still getting an A minus or a B plus average, and you failed my midterm because it's only 10%. It's not going to put that much damage on you. But when you also come to think about it, if you can't pass a cumulative exam that's 50 items that you were given a practice exam the week prior, you should really reconsider on how the way you study. And if you also look at, I'll be resending. Someone just informed me that they didn't get the exam. I sent them out yesterday. Maybe it didn't go out. I was sending it out from my personal PC, so maybe it didn't go out. If you look at your exam, if you're getting like 5, 6, 7 things wrong in a row, the way I designed the exam is by sections. That means you're cramming. That means you're not studying on a daily basis. And I'm not exaggerating by saying daily basis, because repetition equals long-term memory. I also shared with this class and other classes that we do data analysis now regularly on what grades you guys have. The grades from medical terminology, which is a relatively easy course, to this course, which is, it's an okay course. It's not hard. But gang, we're going for middle states accreditation. It's going to get a lot harder. So your other classes are going to follow suit. You'll start seeing in the next year, a lot of your professors aren't going to accept late papers and late assignments. Because when you think about it, when you go to the other, other larger universities, they don't accept late assignments either. So my own alma mater of Rutgers University now has a moratorium on lates. If you don't take the exam when they tell you to take the exam, it's an automatic 0. This is the first term that I actually did that anyone who didn't take the exam, I didn't give them a shot. I feel bad about it because I know the reason why they didn't take the exam is legitimate. But again, like I said, the standard is the standard is the standard. And we must live and abide by that. And the NCLEX pass rates are witness to it. Medical school and nursing school enrollments are high, but guess what? So is the failure rates. And my own alma mater, we're failing a record amount of people. And it's not because people are dumb. It's not because it's just because nowadays the standard is set pretty high. And the people who make it are the diligent people, the people who study every day, no matter what's going on in your life. And that's another little public service announcement that I have to put out, and that Dr. Lexima will definitely put out. And you'll hear it from her own words. No one cares about your personal life. We do. This is undergraduate, but when those of you who already work in the field, they really wouldn't care less, because I have to care about my patient first. So no matter what's going on in my life, my patient comes first. And that's why there's a high maybe you guys saw some articles now that a whole bunch of people, especially in healthcare, are resigning. My daughter is one of them. She lasted not even a year and a half in nursing. Now she's a businesswoman. And the thing that she fought so hard to get and to work as, she's like, nah, I'm not going back. And I asked her why. He goes, it's crazy stressful. I'm not getting paid what I thought I was going to get paid. I don't get paid on time. But again, it all goes back to your passion and whatnot. So I'm going to get off my soapbox now. I just wanted these public service announcements to sink in with you guys, because I hate around week 8, week 9, when I have to inform nursing candidates, or when Miss Briscoe, your nursing coordinator, has to inform nursing candidates that they're not being accepted into the School of Nursing. I had a couple of hard conversations this weekend with people who failed the T's more than twice. And I don't want to have those conversations anymore. But unfortunately, those are the conversations that we have. So please, guys, don't fall into that, please. Because there's a whole bunch of you who are already in the nursing program who are already on academic probation. I think there's like 30 of you now, some ridiculous number. So please do your due diligence. Ms. Coker, you had a question.
Yeah, so you're only allowed to take it how many times? The T's.
See, that's the question. Because my understanding was 2. And then now somebody else from another campus is telling me 3. But then here's my question. You can't pass one section of your T's after 2 tries. You should really be considering, and I'm being brutally honest here. You should really be considering, like, do you really want to be a nurse?
Yes, and
Because,
how many
because you're like, I want to be a major league baseball player. I played baseball since I was 6th grade. I played it all the way to college. But if I'm not meeting the standard, am I going to be in a professional baseball team? You know what I'm saying? Right? Because it's one thing to have a dream. It's another thing to have the talent and the drive and all of that put together to do it. And there's a standard to it. And it was the same thing in medical school. I always quote this number because they said it to us the first day. 444 of us, more than 40% of us already had master's degrees when we went to medical school, right? 444 of us came in on day 1 in a school that was ranked 113th in the country. We're not even a good school. How many of us survived? 68. Out of the 68, only 45 passed the boards. So when you see a doctor, no matter how bad they are, you're already looking at the top 5%. You're looking at someone who survived all of that. Same thing when you look at the nurse. You're looking at someone who survived a lot of cuts. So please, everybody on this call, everybody on this class, be that 5%. But the problem is you got to perform at that 5%. So don't look at the minimum standard like, how many times do I have to take this exam? See it as, I'm going to pass it, I'm going to ace it, not get the minimum score the first time around. And let me give you a little bit of context because many people are from different countries. My daughter came to this country from the Philippines with okay English, conversational. She came to this country, 13 years old? She took her T's at 18. She scored the 94 percentile. So what does that say to you? And she did it the first time around, all sections, not just the reading comprehension. Okay? So what does that mean? It means that what? She worked her tail off, right? And English is not her second, it's her third language. She speaks 2 other languages on top of it. And it was hard. It was really hard. And goes, but when you train every day, which she did, and you do practice exams a lot. Every person I talked to who failed, I did some exams, I did some practice exams, right? Yes, Ms. Coker.
So how many sections?
Just 1, your reading comprehension. You take all of them, but the only score they look at is your reading comprehension.
Okay.
That's it. So shouldn't you ace it? Right? My daughter actually kind of laughed. She said, you guys are only taking 1 section? And she's like, how's that fair? And then I said, well, that's our university. We want to give people a chance. She's like, and she said the same thing that some of the nurses said. We're not giving you guys a chance. We're already starting you guys slow. And there's now a growing concern that maybe we should ask for the entire exam. Because like I said, there's a whole bunch of you who are in the nursing program who are not doing well. And you're already failing nursing 110 and nursing 100. That's your first class. And you're already failing it. What's going to happen when you get into the real classes, the 200, 300 level NSG courses? And that's what we're finding. And everyone on this call, do not be that person. Start off from scratch, the higher caliber candidate. Don't be that person, please. I had to make 2 very hard conversations on someone who scored 58 twice. How do you score 58 twice on the reading comprehension? Oh, by the way, the person is a native English speaker, which made me crazy. All right, because you had your whole entire life to work on reading comprehension. But what do we do as adults? And I'm guilty of it as well. We don't work on the things that make us uncomfortable. God bless. Right. So, gang, if you're not good at exams, get a call out to me. If you're preparing for the T's and it's half-heartedly, and maybe you didn't sign up yet for the Moodle T's, get a call out to me, because honestly, these heartbreaking conversations I'm having every weekend with some of these students is just, it's killing my soul, ladies. And I hate doing it, because you guys are the, to be honest, this is my 6th school that I work for. You guys are the nicest students I've ever had. And I hate having these awful conversations where I'm saying to the candidate, hey, maybe nursing's not for you. And then, and that's because how many times someone had that conversation with me because I wasn't making the grade. Now, the difference is what? I snapped out of it, or whatever I was going on. Oh, by the way, I'm not your straight A student. I was on academic probation in medical school 3 out of the 4 years. Oh, by the way, I still graduated with honors. And if you want to hear that story on how I did it, that's something offline. But if you didn't do well, focus on the things that you didn't do well. Take emotion out of the equation, and then look and analyze what exactly went wrong, right? Even on your midterms, which I'm gonna resend back to you guys. But the majority of you overall did really well. But I just have to be honest with how the scores panned out. Anyone have any questions before we begin? Anything else about the application? And because 95% of my students are nurse candidates. If not, let's get this show on the road. And it is now week 6. What's due today? Week 5 material. And again, I got to get that commercial out. If during the week you're doing, let's say you're doing a task, or you're doing your discussion, and it's not being fruitful, don't just sit there in misery. Get a call out to me. You know, text me, email me, and then maybe we can have a quick. Sometimes all it takes is a quick 20-minute Zoom session, just to point out where and how do you look for things. Because many times it's just a matter of perspective. It's just a matter of where to look. So today, what's due? Task 5, discussion 5, and of course, lesson 5. And what are we doing today? We're going to continue on the cellular stuff, but now we're delving into the heart. This is some hefty stuff. We're definitely not going to finish today, and it's going to leak into other extra videos. So let's jump right in, and let's go into chapter 19 of our textbook. And the heart's really important because, you know, that thing stops. Guess who else is going to stop? Your lungs. Your lungs stop. Guess who else is going to stop? You see, it forms a chain reaction. And that's why when we have a patient with a myocardial infarction or a heart attack, I'm not too worried about the heart attack. I'm worried about all the horrific things that are going to happen that are going to come right after it. And if you understand your anatomy and physiology on how that all fits together, then pathology, which, by the way, is the most failed course in the School of Nursing, that next to pharmacology. Oh, pharmacology, I know exactly why. It's the math. And it's very good, the mathematics that are involved in pharmacology. But that's why we're meeting with the nursing professors later this week, because we want to see what kinds of topics that we got to bolster in anatomy and physiology 1 and 2, so that when you go into pathology, you'll have a better time. And in pathology, they don't have time to tell you what's normal. They assume you already know it. So what are we doing in this chapter? You got to know the interior and exterior parts. So right off the bat, what are you doing this afternoon or today? You're starting to look at pictures of the interior and exterior parts of the heart. Path of blood, which is the cardiac cycle. And I'm going to go over, well, I'm going to share with a video on your announcements of something called the box diagram. It is the path of blood starting at the left atrium through the entire cardiac cycle. And of course, a cycle means it starts in the beginning and then ends in the same place. So it's a trace of a single drop of blood from the left atrium all throughout the entire circulation, and then it'll end in the left atrium. And it can help you on not only anatomy, physiology, it also can help you with your future pathology needs. And I'm going to show you examples of that. We're going to look at how cardiac muscle is different to skeletal and smooth muscle. So we'll be going over the 3 different types of muscle. And a little bit, not a little bit, actually, we're also going, since it's a muscle, we're also going to be talking about how the nervous system links into the muscle and how it actually controls heart rate and the force of contraction. Not going to go over ECG, right? Now, do you notice here? They said cardiac cycle twice. So what does that mean? That box diagram is extremely important. Cardiac output and heart rate, I'm just going to briefly mention it. But again, for your pathology, you're going to have to be able to calculate that formula. But I'm just going to mention that formula and what we use. But we're not going to go over math. For those of you who are allergic to math. And oh, by the way, I used to teach remedial math. And so that if tutor.com isn't working out for you and you're not good at math, and if you're not good at math, join the club. But you guys know that that's what nurses do all day, every day. So if you're not good at math from the get-go, get better at it, because that is your job all day, every day. Who do you think checks all the meds? Physicians, we just write the orders, right? Unless I'm in trouble, unless I messed up, I don't check and recheck every single calculation for every single meds. But the Department of Nursing, that's what they do all day, every day. So let's look at some basic location of your heart. And this is your mediastinum. Okay, it's located in your thoracic cavity of your chest. And you can see from the side view, it's bordered by, you have your sternum here in the front and your diaphragm, which is that thin muscle that we discussed in respiratory. And then you have, of course, your vertebrae and all that stuff here. But what's a better picture is this. Now, the heart is roughly about the size of your fist. It's mostly on the left side. And if you look at the heart, you look at all these tubing, and these are all called the great vessels. If you look at the great vessels, they're either labeled red or blue. Now we know, and you'll definitely know when you do some dissection, that your insides, and those of you who cook, your insides aren't red and blue, but you have to know the difference between an artery and a vein. So if it's red, it's most likely an artery. But what's more important is that if it's labeled red, the red blood cells that are flowing through this blood vessel are oxygenated. Meaning to say is the red blood cells are carrying oxygen. Now it's blue, it's deoxygenated, which means the red blood cell is carrying mostly carbon dioxide. Now, oxygen we need for fuel, and the carbon dioxide is our exhaust. It's our waste product. After, we use up the fuel and then we got to get it out. And the function of this heart is to pump the blood, which has red blood cells in it, to carry these gases in and out of our system. And also to carry the blood here, the deoxygenated blood, into our lungs. So my lungs can do what? Exhale that carbon dioxide, inhale oxygen, and then it runs this cycle over and over and over again. So what do we need? We need oxygen. What do we need to get rid of? Carbon dioxide. And you'll see here that there's these little tiny arteries and veins that cover the entire surface of the heart. The the heart is an organ and it needs its own blood supply. And all these little things here, and we're going to discuss them in greater detail, those are your coronary arteries and veins. And they're important because they supply the oxygen to this heart. And then the coronary veins then get rid of the carbon dioxide and then shuffle it out of the heart so that the heart can maintain pumping and be viable. But when you have a heart attack, for example, we're going to talk about this thing right here. This is your left anterior descending coronary artery. Now, if you have a heart attack, there's a blockage here. So if I have a little tiny little blockage here, what's going to happen to this entire left ventricle? It's going to die, or it's going to start to die. And that's what a myocardial infarction is, or a heart attack. Myo meaning muscle, cardium, cardi meaning heart, structure of the muscle of the heart will then be an infarction is a blockage. So that's what a heart attack is. And most commonplace right here, left anterior descending artery. But we'll look at that in a better picture. CPR. Oh, and those of you who aren't CPR certified, don't get the cheapy $22 online CPR course. Spend a couple of bucks. There's a $98 and in some places as high as $120, $130. It's a CPR, basic life support / first aid for medical professionals. That's the one you should take. That's the nice one, where it teaches you also first aid. And even if you're not in really a current clinical position, it's nice to have, because you don't know when you're going to need it in your personal life. For example, my wife was, before she worked with Inova, she was a office manager, and she had that more advanced stuff going on, right? And a patient was bleeding out in her hallway, right? So what did she do? She did, because even as just as a person who's only working the front desk and doing insurance calls and that kind of thing, she was able to do, to help some critical care before the ambulance got there, which was really nice because she had that training. And which, by the way, I'm not sure about Inova, but I know for a fact Centara, they require it. Even if you're, I have a student who graduated last year, medical assisting. They require clinical skill sets even for their front desk personnel, because they know and understand you never know. Something horrific could be happening in your front desk, and the people who are working the back rooms or the clinical rooms may not see it or hear it in time. And those of us who took CPR know that the golden 5 minutes, that's 5 minutes. If your heart is not beating and not delivering oxygen to the rest of your body for 5 minutes, there is irreversible brain damage. And that's what we're trying to avoid. And that's why we try to get as many people to know and understand CPR, to help with that in the interim while the emergency medical service comes into play. Here in Northern Virginia, the response times are awesome. I lived in New York City, where the response time, depending on the neighborhood, some of the response times were almost like 6 to 10 minutes. Here, it was around 2 to 3, which is really awesome. Now, we look at this. The first thing you have to understand when you're looking at a picture like this, let's look at a more detailed picture. These are nice. Is there a more detailed one? But just right off the bat, if we're just looking at this, the first thing you have to look at is orientation and perspective. So when you're looking at the patient, where is the patient's left? This is your patient's left, this side. And where's your patient's right? It's this side. You'll also notice that everything on this side seems, the majority of it's red. That's oxygenated. And the majority of the tubes here on the left side are blue, and that's deoxygenated. And that signals, if you look at this, there's two separate kinds of circulation going on in your cardiovascular system. Cardio meaning heart, your vasculature meaning all the tubing that connects to your heart. So all this stuff here that's deoxygenated, that belongs to the pulmonary side, or your pulmonary circulation. And it makes sense because if the majority of my red blood cells are carrying carbon dioxide, that means that it has to be replenished. So where does all this stuff have to go? It's going to have to go to my lungs because it has to be replenished with oxygen. And you have this, the aortic arch and all this, they're all colored red because that's oxygenated. And they call that the systemic circulation. And that also makes sense because if you have oxygenated blood, where does it need to go? It needs to go out into the rest of the body or rest of the systems so they can feed the rest of the systems oxygen, which we know is a vital component to make ATP, adenosine triphosphate, in our mitochondria. So you could see how our previous lectures, even though they're separate, everything all links together and everything has its purpose and makes sense. So I could ask you, which side is the pulmonary side? And you'll tell me the right. Which side is the systemic circulation side? And it's the left. So you could have right-sided heart failure. That's called cor pulmonale. You can have right-sided heart failure, right? Also known as cor pulmonale, when you have serious lung problems. And it makes sense because if I have a serious lung problem, don't you think it's going to back up pressure into the right side of my heart? And then my right side of my heart's going to have some trouble pumping this blood out. And you could also see what we talked about before. If I have a myocardial infarction that's going to affect my left ventricle, don't you think my heart will now have some trouble pumping blood out to the rest of my body? And that's why when you get a heart attack, you get dizzy, shortness of breath, right? And of course, pain and all the other associated things. And that's the hard part of pathology, when if you don't understand the source or the anatomy and physiology where things came from, you're just going to try to memorize everything. And that's not a good idea, because what happens in stressful situations, you start flipping everything around. But if you know and understand where everything's going on, right? So here's a classic pathology question. My patient is presenting with cor pulmonale secondary to COPD or chronic obstructive pulmonary disease. Which part of the heart is going to have abnormalities upon their EKG? Now, that sounds like a very hard question, but now that you know your anatomy, you're like, wait a minute, the pulmonary circulation is on the right side. So it has to be what? A right-sided problem. And therefore, I'm going to look for right-sided problems on my EKG, right? Which is your electrocardiogram. And right now, you just solved what? A medical school question. My patient has hypertension. So what am I going to be looking for? Which ventricle is going to be messed up? I know that my systemic circulation is where? Left side. So who's going to get bigger? Who's going to get messed up? Your left ventricle versus your right. And hence, that's why left ventricular hypertrophy or left axis deviation on an EKG is more common, because how many people in this country have, or in this world, have hypertension? And if I have hypertension, right, all my tubes are now tight and now increasing my blood pressure, what's going to happen to the heart? You're going to have cardiomegaly, and that's not good. You're going to have left ventricular hypertrophy. That's not good, because as we saw here previously, is there a lot of place for my heart to grow? This is the last thing. This is the last muscle in your body that you need to grow. This is not good if that grows out of hand, because then it gets all tight and everything will be, all the pressures will start backing up. Now, the heart has layers. And if you took my medical terminology class, this part should be no problem with you. because you learned your medical terminology prefixes. So you have an outer layer called your pericardium. Peri means surrounding. It's fibrous, it's tough. When we do that dissection, it's hard to even rip with your hands. Now we have two other layers of your pericardium. You have your visceral and parietal. And in between the visceral and parietal layer, you're going to have a potential space that has a little bit of fluid, pericardial fluid, in this pericardial cavity. The function of that fluid is to make sure that, because the heart is pumping all the time, make sure it reduces friction and, it's like slippery. But what happens if there's blood or pus in it? And then we got bad news. So the outer layer is called the pericardium. There's two layers. You have your visceral and your parietal layer. And think viscera means guts. So that's got to be the inner layer. And the parietal layer is simply the other one. When you have two things that you have to memorize, like visceral versus parietal, memorize one like your life depends on it, and the other one is the other one. To this day, every time I think of visceral versus parietal layer, I think what? Viscera, guts, the one on the inside. So could I easily show this picture and this shows A, B, C, D, E? Sure. What's the function of all of them? The pericardium, protection. Pericardial cavity, potential cavity space that has pericardial fluid in it that utilize it to reduce friction within your heart. The next layer is your myocardium. That's the muscle layer. It's the thickest layer. And the last layer is your endocardium. You see how thin? It's delicate. So if you have a heart attack that only affects the outer layers, you're okay. You're probably going to go home this afternoon. If your myocardial infarction is getting into the level of your endocardium and on the deeper levels of your myocardium, don't make any plans. You're going to be here and we're going to be admitting you for a while. So if I don't supply blood to this area, what happens? The damage will get deeper, deeper, deeper. And that's why you need to know the layers. So if you know that my patient has a class 3 subendocardial myocardial infarction, what are you going to say to them? Right? You're going to, well, as a physician, I'm going to say, don't make any plans. We're admitting you to cardiac care unit immediately. Yeah, but I feel fine. Yeah. Well, your heart isn't fine. And that thing I told you about with the pericardial space, if that thing fills up with blood, what happens? It's going to start squeezing on this heart, and it's going to cause something called pericardial or cardiac tamponade, which is no bueno. And there's a whole bunch of signs and symptoms that are classic but again, this is not a pathology class, but you can now see, knowing and understanding the layers and what the functions of the layers, you will get to know and understand what are its effects, especially when things go bad. And you can easily get pericardial tamponade. My last patient, she was a 34-year-old female. She was driving her car and she ran into a big semi-truck and she had a compression fracture of her chest and sternum. Now the sternum, when it hit the heart pretty hard when she hit the dashboard. So all of this crushed in, and then all the remember the, what do you call that? The coronary arteries and veins started leaking blood into here, and then it started squeezing on her heart. Right, and then you can see all the classic signs and symptoms: distended neck veins, of course, dyspnea and difficulty breathing. Blood pressure is going to be through the roof, right? And what do we got to do? It's easy. Well, not easy. Ultrasound guided right through the bottom of your sternum. We stick this large gauge needle, and we find the heart, we find the pericardium, and we drain it. Oh, this is the detailed picture that I like. So I could sit here and go through each and every one of all these things, but that's your job. Do you think you can easily find a quiz online and then quiz yourself 5 minutes every morning? Remember what I talked about, that due diligence? Quiz, cardiac anatomy. Oh, looky here. I could do that. I could do that. I could do that. I could do the same exact picture. I could do that. Right? How many of you actually practice for an exam? Actually train how you are to fight? That's why I scoff at the, what do you call that? I always tell the story because it is an analogy to train how you are to fight. You know you're going to have an anatomy and physiology exam in about 4 weeks, right? And it's 10%. It could mean the difference between an A and a B and a B and a C. And for those of you who are nurse candidates, do not be in that B to C region, right? It's too dangerous. B minus and above, right? All day, every day. Or how's this? Just get all A's. How's that? Right? I know that's a tall order, but we are in the tall order business. Now, when you're looking at this, remember, when you're looking at anatomy, first you got to ask yourself, where's my right? Where's my left? And I'm looking at my patient, and this is the left side, and this is the right side. The next thing I also have to ask myself, am I looking at the front or am I looking at the back? How do I know I'm in the front? You see these atria, right? This is your left atrium, this is your right atrium. They're here in the front. And if you look at the aortic arch here, it's going towards the back. So that's how I know I'm looking at the front. Another reason why I'm looking at the front is because this anterior interventricular sulcus, now it's called a sulcus because it's a depression. It's like a little ridge or a little, a little groove. That's the best way to put it. And within that groove, you have your great cardiac vein, and you have more specifically left coronary artery, which is more specifically your left anterior descending artery, which we talked about earlier. And you see how it runs diagonally here from your left atrium down here and your apex. So this interventricular sulcus separates your left ventricle, which is here, and here's your right ventricle. So if I point at this area and ask which ventricle it is, you'll tell me left. If I point at this area, you'll tell me right. If I pointed, and these atria are exaggerated, but if I looked at the little room that's on top and it's on the right side, that's got to be a right atrium. And this little one's got to be a left atrium, okay? Now, aorta, which is your largest artery or largest diameter artery in your body, you see how it's curving back and it's colored red. Your exam, of course, will be in color, right? So that's how I know this is a major artery, and that's your aorta, okay? Common carotid arteries, subclavian arteries, and brachiocephalic arteries. They are all arteries, and they're all colored red. You could see this one. This is your superior vena cava. It's bringing deoxygenated blood from the top of your head into your left atrium, right? Your inferior vena cava, which brings deoxygenated blood from the rest of your body or your trunk, from your neck on down up into your left atrium. You'll notice you're going to have two sets of pulmonary arteries and pulmonary veins because you have two sets of lungs. Now, you'll also notice, like, wait a minute. It goes, oh, well, we'll talk more about this later. But you could see here, there's one set of pulmonary veins, right? Going to my, connected to my lungs. And here's another set. So this has to be the right one, and this has to be the left one. And you have a right pulmonary artery here and the left pulmonary artery here, okay? And if you look at this, it's blue. The pulmonary artery is deoxygenated. Your aorta is oxygenated. Now, I could look at this as well. The first thing I have to ask myself, what's right and left, what's up and down? Now, how do I know that this is the posterior portion, our posterior view? Well, you can see the aorta, it's coming back here. Yeah, it's one thing. But do you see the right and left pulmonary veins? They're prominent here. And I don't see much of my atria. See how it's only a little bit here? So that's how I know I'm in the back. Also, you'll see this huge blue thing, which is your coronary sinus, which leads into your posterior interventricular sulcus that has your posterior interventricular artery and your middle cardiac vein. And you could see, this is not the best picture, you could see how it's like running, it's not running diagonal, it's running straight towards the apex versus running diagonally away from the apex. So this should scream to you what? Oh, this has to be my posterior view. So if you're in posterior view, then you have to have posterior view thinking, okay? So before you hit any picture or any identification on the exam, and again, can you look up online and find a quiz, or you could take this, copy and paste it onto what do you call that? Like a Microsoft Paint, and just erase all of these. What do you think I did to make exams? I found the picture, or I took this and I erased it all. And just imagine if you just work on it every day until the end of the term, just for 5 minutes. Make yourself a quiz and quiz yourself. The first couple of days, you're going to do poorly, correct? And then what happens? After repeated practice, right? So think about it. Repetition equals mastery. So the more times you repeat it, the more times you get to know which arrows are which and where where's what. Then it becomes second nature. I love telling the story. I had a student, she finished her Anatomy and Physiology 1 midterm in 16 minutes. She aced it. Why? Because she did exactly what I told you guys. Look at the pictures, because there's a lot of pictures to be held here. Look at this. So let's look at the internal structures. So right off the bat, I have to ask myself, is this front or back? What do you guys think? If I'm looking at this, is this front or back? It's front. And because my atria, they're here, even though it's cut open, my aorta is like going to the back. So I know it's front. Now, we could do a better picture with the layers, but if I point here, this is definitely myocardium. If I point in the inside, it's definitely endocardium. So let's look at some of these endocardial functions. Now, in real life, it's hard to look at these things because no two hearts are created equal. But do you see this thing here? Doesn't it look like fingers? And what is another word for finger? Papilla. So these are papillary muscles that are connected to these strings or cords. So that has to be the chordae tendineae. And the chordae tendineae connect to a cusp or a leaflet or a door. And this door is called an AV valve. It's because it's in between your atrium and your ventricle, hence the term AV valve. You also have one here. On the left side, it's called your mitral valve, also known as your bicuspid. Doesn't that look like a beautiful both A and B question? And if you notice, bicuspid, bi means two. How many papillary muscles do you see here on this diagram? 2. So it's a hint. 2, bi, right? Because the diagram is going to try to be as accurate as it can. In real life, you got to know where right and left is, because when we do a dissection of the heart in a couple of weeks, you'll see how muddled it gets in real life when we cut open a real heart. And I think I bought the big hearts this time. So as in big, as in the size of a basketball, big. I got to check my lab. I haven't looked at my lab in 2 weeks, so I'm going to be doing that later today. So that's your mitral valve. So if I point at this AV valve, you know it's AV, atrial ventricular. Now, do you notice also, do you see how rough the wall is on the ventricles? And do you see how thick the walls are on the ventricles? Because the ventricles are high pressure. But if you look at the atria, smooth walls, very thin walls, because they are low pressure. You have another AV valve here with 1, 2, 3 papillary muscles connected to chordae tendineae. Hence, this is called a tricuspid valve. Okay, so if you know your anatomy and physiology, you know the tricuspid valve is on your right side and your mitral valve is on your left side, right? You can now know and distinguish murmurs, because what are the sounds that the heart makes? Heart sounds are made from doors opening and closing. And these are doors, your tricuspid valve and your mitral valve. They're doors. And you guys know, some of you have an old door in a house that you love, but after a while, right, the door is a little bit messed up and it makes a funny sound. Hence the term murmurs or pathologic murmurs. For example, here's a medical school question. My patient has a chronic history of a drug abuse, especially heroin, with needles. Okay. I guess we did a test in his blood and we found that he has significant bacterial and fungal infections in his blood, most likely secondary to chronic drug abuse. Okay. Now, I know with heroin patients, vegetations love growing on the tricuspid valve more than any other valve. So here's the medical school question. What side am I going to hear the murmur? If I have crusty bacterial vegetations on my patient's tricuspid valve, right or left? Anyone, call it out, right or left?
The right.
Where are you going to hear the murmur?
Is it
On
the
this
right
page.
side?
On the right side. Yeah. You just answered a board exam question, right? Because you know your anatomy. Just imagine trying to memorize where all the murmurs are. It'll make you insane, right? And actually a murmur in medical school, murmur interpretation is hard. It's very hard. You got to go through like at least 100 patients, but nowadays they have this newfangled 3D Bose headsets where everything's like virtual reality now. It's like the most insane thing, which by the way, if you guys look at your lab 3, the nursing lab, all those mannequins in there are level 3 and level 4 mannequins. That means, and one of them I believe talks to you. I haven't seen that yet, which is going to freak me out if ever I go in there, because if I see one of those mannequins start talking to me, I'm a little bit superstitious, so I don't want to be around that. I'm the last generation of, I went to medical school in the 90s. I'm the last generation that didn't have simulations. The way they taught us is you go inside an urban healthcare center with 500 patients and you see as many of them as you can. Actually, that was my exam for murmurs. I remember in medicine 3, in third year medical school, they put you in a room full of real patients and you go through like 20 patients and then they follow you around and you just have to diagnose all the murmurs. And your score is based on your accuracy. I did okay last time I remember. I'm pretty good with stethoscope. I'm all right with it. It's surgery I'm bad at. I did some horrific things. Oh, here you go. So you can see here how, they picked, of course, an awesome specimen. But you can see here, they look like little fingers. You got to use your imagination a little. And you could see the trabeculae carne. You know that you're in a ventricle because look at this. It's all rough. And see that thick wall here, right? And then you have your chordae tendineae, your cords. And what's a cord, right? It's a rope. And then it connects into here. And here's the this more of this part here, this white part. And those are the leaflets. Okay. All right. Look. This is the top view of what it looks like. And here is your aortic and pulmonary valves. And I'm going to show you a different view. Now, they call these valves, your aortic and pulmonary valve, the semilunar valves, because when you look at it, sideways, it looks like a crescent moon. So what are these valves? Because now we talked about these valves, the AV valves. Let's talk about this valve here and this valve here. Now, you have the right ventricle, which is going to lead into your pulmonary artery because I have to get this deoxygenated blood back to my lungs so I can fill it up with oxygen. And you see this looks like a little, got to use your imagination a little bit. It looks like a little crescent moon here. And that's your pulmonary valve, also known as your pulmonary semilunar valve, also known as pulmonic semilunar valve. And that's the valve that empties from your ventricle out into your pulmonary artery, then into your lungs. Hence the term pulmonary, 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 right? Now, let's look at the left side. Here's your left ventricle, systemic circulation. And that goes to your aortic semilunar valve, because from here, it goes to the aortic semilunar valve underneath this, and then into my aorta, and then into the rest of the circulation. You can also see here, remember, ventricles are high pressure. If I have an aneurysm, or I have a weakness in the wall here, or a weakness in the wall here, in this pulmonary artery, which is relatively rare, and the aorta here, my aunt, she passed, I think, how long has it been? A couple years back, she had an aneurysm right here. Zip. She went into the bathroom. She was feeling a little bit dizzy. And then they found her on the floor. And she was dead. Why? High pressure, little nick in the wall here. What's going to happen? If this bursts, you got minutes. You're done. And it goes end of the line, right? So, and it was quite shocking because she was healthy. But if there's a little defect in these walls, especially in the high pressure, and that's what an aneurysm is. It's a defect in the wall, and never a good thing. So now you know the two kinds of valves, semilunar valves and your AV valves. Your AV valves, tricuspid on the right, bicuspid on the left. Aortic semilunar valve is coming from your left ventricle, going into your aorta. Your pulmonary semilunar valve is coming in from your right ventricle, going into your pulmonary, which is your lungs. And these are the kind of typical questions I could ask on an exam. Where's the blood from your pulmonary valve going to? Of course, pulmonary artery, then pulmonary, and going into my pulmonary, which is my lungs. Where is the aortic? Where's the aortic semilunar valve going to? And empties out blood into where? Into my aorta, out into the circulation. And more will look a little bit clearer when you watch my video on the box diagram, which I won't be presenting today, but I'm going to give it to you. I'm going to be putting that link so that you can digest that during the week. But before you look at the cardiac cycle and the box diagram, hit up this one and hit up these two first. Get familiar with the external and the internal structures of the heart, which we just went over, and then hit up the box diagram video, which talks about the cardiac cycle, which is the trace of a single drop of blood from your left atrium all throughout the circulation. So let's see. Oh, look here. And you can see how the mitral valve, it looks like an upside down parachute, and that's actually how it catches blood. So it kind of catches blood here, but then when the chordae tendineae get pulled from the papillary muscles, it pulls on it, and then the blood will do what? Fall down. The blood up here is low pressure. So it goes whoop, it just falls down by gravity. Well, not really by gravity, that's a misnomer. It's by pressure gradient, always from a pressure from high to low. Coronary arteries. Now, those are the things that surround the heart, and they supply the heart. You have your circumflex that goes around, hence the term circum. Circum means going around, right? Anterior interventricular artery, also known as your left anterior descending. Great cardiac vein, we talked about that. You also have your small one here on the side, marginal. You know when something's on the marginal, it's on the side, the margins. We look at posterior, of course, your middle cardiac vein, and right coronary artery. Nice to know, posterior cardiac vein, posterior interventricular artery, and it's coming, all of that. And also the big one here on the posterior view is the coronary sinus. And you could see, if you look at an angiogram, angio meaning blood vessels, look at this bad boy. See, it's supposed to be like this thick. Ugh. You know what this is? This is Doritos, that extra beer that you had that you shouldn't have. the extra slice of cheesecake. There you go. This one right here is that chili dog you ate yesterday, right? And remember, what happens when fat and fatty plaques get in here, and you can see how small it is. This is very small. This is only millimeters. It doesn't take much to get a heart attack. That's why nowadays bypass or cabbage coronary artery bypass grafts are very common. When I was in training, it was still in the 90s. It was still, you know, a serious thing. But nowadays they're like they schedule that stuff left and right. Now, what's so different about cardiac muscle? Well, what's different about the cardiac muscle is it has autorhythmicity. Where's the word here? Here it is. Auto means self. That means it contracts by itself, and it forms what they call a syncytium. That means that they're connected. So let's say, for example, you have two heart cells. If you separate them, they'll beat at different paces, right? One may be at 80 beats per minute, and the other one will beat at 90 beats per minute. But when the second they start touching, the cool thing about cardiac cells is they start beating together, and they start contracting together. Okay, and what else is important is they also have these things called intercalated disks. Now, what's important by that is not only that communication in between cells, they also have a lot of calcium, and calcium is very, very important to jumpstart your heart and to get it beating. So it's a syncytium. It has autorhythmicity. Now let's look at the conduction system of your heart. Now, your heart is simply a muscle, and all that a muscle does is contract or get smaller. That's all it does. But our heart contracts and gets smaller in stages, in sections. And from that, it turns into a pump, the most powerful pump, I believe, in the whole world, because this thing started around week 6 when you're inside mommy's uterus, and it will keep on going till the day you die. Hopefully it doesn't get interrupted, but it should keep on going. And these are the parts, but let's look at this lovely video. And I'll have this available, cardiac conduction system. I'll have this link available as well in your notes. So let's look at this and break down this video.
I'm Sarah Oda. I am a senior at Stanford University, and in my free time I do.
The cardiac conduction system consists of the following components: the sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles.
Okay. So you have your SA node, and they call that the pacemaker. The SA, or the sinoatrial node, is called the pacemaker of your heart. It beats around 100 beats per minute, but that's a little fast because we're going to need time for the blood in the atria to get to the ventricles. So we need the AV node. And the AV node is kind of like, they call it the gateway or the gatekeeper. I call it the brakes, BRAKES. It slows down and it provides a pause so that this blood in the atria can can go down into the ventricles. And like I stated, if this thing starts to close, what's going to happen? It's going to increase pressure up here in the atria. So the pressure will be higher here than in the empty ventricles. So blood will then go what? Down. I misspoke earlier that I said it's gravity. It's not gravity. It's pressure gradient, always from a high to low. So I could ask you, what's the SA node? You'll tell me, oh, it's located here in the right atrium, and that's your pacemaker. What's AV node? Oh, that's the gateway or the gatekeeper or the brakes. That will slow things down. That's why your heart rate should be always less than what? 100, right? 100 is a little bit too fast, right? And your AV node should slow it down.
It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG.
All right,
An
so we don't need not EKG class. So let's get to the end part so you can see how it works all together. And you could see from your EKG, it's a coordinated thing.
Responds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction or atrial systole starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation or ventricular diastole. The cycle repeats itself with every heartbeat.
All righty. Okay, so how could I ask that on an exam? I could ask you, which are, because we already talked about, I could have this picture, I could erase all this, A, B, C, D, E, F, G. Where's the pacemaker, SA node? Here. Where's the AV node? Here. Bundle of His. It's supposed to be here. There you go. Your left and right bundle branches and your Purkinje fibers. Okay. I could ask which one goes first. Of course, it goes in this order. SA node, AV node, bundle of His, left and right bundle branches, then Purkinje. Okay. And you'll notice that it's colored yellow because yellow is the color of fat and nerves have a lot of fat. And that's all that these things are. It's nerves within your heart. But you could see if I have myocardial damage, don't you think it'll also damage these nerves as well? And that's also the other danger that we have. And then it's beautiful because I don't have to open up your chest. I do the EKG, which is non-invasive, and I already know exactly where the problem is in my heart because it acts like a little camera without me having to do any invasive procedure. That's why EKG to this very day, if you're having any chest pain or if your vital signs are off, it's the first thing we're going to order because it's a wonderful screening test.
Question.
Yep. Shoot.
So how can the nerves of your heart, like how can they be damaged, the fatty part of
Well,
it?
because when you think about it, the arteries because everything in your body is a living, breathing thing, right? Even your nerve needs oxygen. What happens if this part of my heart dies and doesn't have any oxygen? Everything associated with it, which is living, breathing nerve, is going to get damaged, right? That's why, remember the golden 5 minutes that I mentioned? Any asphyxiation, you're gonna have irreversible brain damage, irreversible nerve damage, and we're very, very mindful of that because we didn't go over neurology yet, but know and understand if you kill a brain cell, you don't get that back. It's done. So those of us who are drinkers, think of every time you were hungover. I wish someone got that idea to me when I was younger. I cannot imagine how many brain cells I lost because of partying or drinking or whatnot. And it's what we also have to get to our younger patients and that message of moderation, because a nerve is not just a wire. It's a living, breathing thing that transmits electricity in our body. And if it is damaged, it cannot be repaired. But the neat thing about nerves is that it finds a different pathway. But when you're an adult, it's very hard to do. And that's also the other reason why, even when your patient has a pulmonary problem or a cardiac problem, they still have to go to rehab. A lot of people think rehabilitation medicine is only, if you broke a bone or have a muscular problem. No, rehabilitation means, what does the word re mean? Again, hab or habitate means to live. You have to live again and learn how to live again with the damage. Because remember, when you get damaged, you don't come back better. And remember those, I mentioned calcium. Calcium and sodium are big on starting the electricity. Potassium is for repolarization or resetting the electricity of the nerves in your heart. That's why if I want to increase contractility, what do? I mess with calcium and sodium. By the way, what do you think we use to terminate the life of somebody on death row? I use potassium iodine. I put potassium iodine, I repolarize my patient to the point of what? They'll never come back, right? So think of like the most basic way to think of this. Potassium is the off switch. Calcium and sodium are the on switches. That's like the most basic layperson way I could explain it. And you'll learn more when you're in biochemistry. Okay, so I could ask, what will increase the contractility of my heart? Calcium or potassium? Calcium. What will reset the contractility of my heart? Potassium. So if your patient, for example, has hyperkalemia, I remember years ago I had a professor, he was an English professor, and I was on campus. And here's the problem of being an MD on a campus that didn't have a healthcare program. I was running a school in McLean. And I had an English professor. He was a wonderful man. He had hyperkalemia. And when I hired him, I told him, is this going to be a problem? No, it won't be. So he had these fainting spells, but it was okay. We got him a hospital. Until one evening, one random Thursday evening, student said, Dr. So-and-so fainted again. And I'm like, okay, guess who had to do CPR on him? He had a massive amount. He had a potassium dump, and his blood was way too much potassium. So it told his heart to do what? Reset, 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 reset. What happens when you just keep on hitting reset? That's just the same thing as saying turn off.
Yeah.
We couldn't revive him, and he passed. And you can see here, this is what calcium channels do. What does it do to the electricity? But you can see what sodium starts it, calcium keeps it going, but then the repolarization, the reset, that's what? Potassium. And gang, you guys want a really quick way how to kill your patient? All you have to do is don't pay attention to your drip, your IV, which is a big thing in nursing. And me and Professor Greninger, I'm sorry to giggle about it, but some of the nursing answers with some of the exams, because what happens if I put way too much sodium or way too much calcium? That's not a good thing either, right? If I tell the heart, open, go, what am I going to do? It's awful. I actually did this twice in my career. I made my patient hypernatremic. What happened to her heart? What do you think happened?
Did it burst?
No, it just, she started having arrhythmia, and then she couldn't breathe. And then nurses ran because Dr. Garais, sodium's up at 250 mex. And I go, excuse me? I woke up real fast. It was like 3 o'clock in the morning because why? I miscalculated stuff. I ordered the nurse to do a certain drip, which was wrong. The nurse, when she checked my mass, she thought it was okay. So she's wrong too, right? We just watched her heart go into tachyarrhythmia. And I had to explain myself the very next morning. Why did my patient almost code? Because why? At the moment, I did not understand my anatomy and physiology, and also what messed me up, basic math. And I did it to that poor woman twice, and I got into a lot of trouble. I actually got suspended for 48 hours. And after my suspension, I had to come back and take a test to prove that I'm not an idiot. And I was already a first year resident, and I've done this a million times. But remember that due diligence, that higher level of standard. You can either be stressed about it or scared about it, or do what? Just live the example and just learn from it. And ever since that day, I triple check my fluids always. Ever since that day, right? And me and Professor Greninger talk about and I told her that story. She was like, and Professor Greninger admitted how many times that she caught other doctors doing the same thing, but as the good nurse, she did what? Corrected it. Saved that patient's life. Because remember, patients come into the hospital not to get worse. They come in the hospital to get better. And if we don't do our due diligence, we can make things worse. And that's why every week there's these meetings for all clinical staff, and they're called M&Ms, mortality and morbidity. We talk about all the patients who died from the last week to present. That's mortality. And all the patients who got worse, that's morbidity. And boy, oh boy, I got roasted alive for that patient. I remember everything about her. And it's been what, 15 years ago, but man, you learn. Wait a minute, not 15. No one's a resident. Oh my lordy. I don't even want to admit how long ago it was. Now, you saw what normal QRST looks like, the waves, right? So you could see how valuable this EKG machine is. Look at this. Look at all these crazy waves. And it's obvious. You don't even have to have education to know, hey, this is messed up. But then, of course, when you guys take your medicine class, we go over all of these.
Do we get tested on the ECG and the NCLEX?
There are ECG physiology questions on there. The NCLEX is more of a critical thinking exam than, hey, what do you do exam? Like a procedures exam. Okay. Oh, which, by the way, when you become a nurse, you have procedures exams all the time to keep your job so that you know the protocol backwards and forwards. But the NCLEX, if you look at the practice exams, they're more of, can you relate your basic sciences two procedural things. And that's what they're trying to assess. Can you as a future nurse do you know why you're doing what you're doing? Because many times, and even myself, I do the protocol to the letter of the law, and then I have to ask myself, why am I doing it? And you're like, oh, I'm doing it because this is the way it's always done. But you should always be asking yourself, I'm doing something for a reason, and knowing and understanding that reason. And that's why you have to take these classes before you take your nursing classes. I had a long conversation with somebody about that. I had a student, she aced all of her classes, she's ready to go, but she didn't make all the requirements and didn't pass her T's yet. She's like, why can't I just take nursing classes and I'm already good? And I go, no, there are stages and they have to be abided by. And it's not our rule, it's the Board of Nursing rules. So we got this defibrillator. Maybe you guys see it with the paddles. Now, all this electricity, it's kind of a funny thing. When the electricity gets all out of whack, it's funny, we use this thing to zap electricity into you. It's kind of like, in cartoons where if someone lost their memory, you hit them over the head with a hammer and they get their memory back. Mm-hmm. I always saw it as a very comical way, crazy way to do it, but it works. We zap the patient with a little bit of electricity and then increasing amounts of voltage in order to bring back order from disorder. And that's what a defibrillator is. And you'll learn all how to use those things as well. Pressure and flow. The only two things I really need for you to really know regarding pressure is you have this term systole and diastole. Now, systole is when your heart contracts. It's doing something active to create pressure, so the pressure will increase. And diastole is when your heart chambers relax in order to reset or to let the blood in. So if you notice, they're in pressures measured in millimeters of mercury. So let's talk about what's normal blood pressure. You'll see the numbers 120 over 80. 120 is your systole, the pressure at which when your heart is doing work. And that's 120 millimeters of mercury. And when it relaxes, it's 80. And that's your diastole or your diastolic blood pressure. Okay. And those are the two phases of your cardiac cycle. So there's a balance. There has to be what? Some squeezing, that's your systole, and some relaxing, which is your diastole. Now, let's talk about this stuff, stroke volume, heart rate. And you can see here, diastole, rest, a little bit of systole, and then what? Big time ventricular systole, and then relax, and then reset in your T wave, and then relax. And you can see all the stuff where it's relaxed. So your heart isn't really just nonstop pumping. There's moments in between, and that's your diastole. Heart sounds we already talked about. You only have two of them that are normal, your S1 and S2. Anything other than that, and your S1 is your lub, and your S2 is your dub. Yes, Ms. Coker, question.
Yeah, so that's why when there's a flat line, that means you're dead, right?
Excuse me?
I said that's why when you have a flat line, means you're
Oh yeah, if you have asystole or nothing going on, yeah, that's not good. And you'll also learn that there's sometimes, especially babies and premature babies, they have what they call systolic pause. But just as a little side note for all of you EKG buffs, I also teach EKG as well, but I only teach it for the medical assistants. I don't teach it for the nurses. But if you want to, and again, you want to review, want to come in and play around, always ask your teacher, you guys paid for the labs, come in on extra days. The people in medical school who did the best in laboratory were the ones who bribed all the laboratory assistants. And me, but now at UMD, it's open 24 hours. But during my time, it was only open at certain hours. the janitor was really into cigars. So I got a friend of mine was from the Dominican Republic and got him these awesome Robustos so I can go to the lab when no one else was there. But I eventually got caught, got demerits, and bad things happened. So don't do that. So what's your lub dub, right? But my message is overall is what? Try to get to lab and if you have lab, practice as much as you can. So here's your lub dub, your S1 and S2, and they correspond to when your AV valves and semilunar valves open and close, and you only should have 2 sounds. So I could ask you, what makes the heart sounds? It's when AV valves and semilunar valves open and close. So you're going to hear a lub and a dub. And when you get a little older, you get an S4, which is somewhere here. But S1, S2, that's normal. Now, if these things don't match or these things don't, oh, by the way, you're going to eventually need to know all the pressures and things like that. But for now, for my class, no, right? This is a classic, for those of you who want to go to medical school, this is a classic medical college aptitude test question. And you know how I figured out this? I just practiced drawing it by hand. And then so by exam time comes, I know exactly how things go down. But for my exam, for in the next 4 or 5 weeks, it's only what's lub, and you'll tell me S1, what's dub, S2, what does it correspond with? It corresponds with AV valve closure and opening and semilunar valve opening and closing. And you could see here, when an AV valve closes, the semilunar valve has to open. When the semilunar valve closes, an AV valve has to open. Makes sense, right? So that's S1, S2. And look at here, medical school question. Now that you know your anatomy, you know where they are, right? But this reserved for, and this has exact locations on your chest via your intercostal spaces, but that's for future training. Okay, now this is the math thing that I was telling you about, but not for my exam really, but for you to understand if you take advanced courses, you have to understand that everything in the heart can be measured. And one of the things we measure is this cardiac output. Now, what's the cardiac output? The cardiac output is the heart rate, or how many beats per minute, times your stroke volume. Now, what's your stroke volume? The stroke volume is, let's look at the, here you go. The stroke volume is the amount of blood pumped by each ventricle, right, during each pump. And the heart rate, of course, is the contractions per minute. And then you have your end diastolic volume and your end systolic volume, right? So eventually there's going to be problems where you have to fill in the numbers. But if you know and understand that my cardiac output is heart rate times stroke volume, and the worst I'll do to you is, where do you get the heart rate? Well, you get it from your vitals. Where do you get the stroke volume? Well, you measure it from, you can do it via ultrasound, and diastolic volume minus and systolic volume, and HR times SV equals CO. I'll maybe ask one question on it, but eventually you could see how they can have problems where, oh, if my patient's heart rate decreased by 20%, what would the cardiac output be if the stroke volume was yada, 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 yada. But if you know this little diagram right here, solves all of that, okay? And you could see the factors affecting things. Like also another thing here, when they talk about autonomic intervention or innervation, what's your level of stress? When I was in medical school, my standing heart rate was, I think, 89 beats per minute. And now, well, maybe not now, but when I'm actively working out or running, it's around 50. So, because if your heart rate is less, the stroke volume has to compensate for it, because your cardiac output must remain enough so that you can live. And that's what we measure, especially when you get heart attacks. Okay. And that's why when you exercise, it's just so much beneficial for you, because it increases your cardiac output on a regular basis. So when your heart's in trouble, your heart can compensate for any problems. And autonomic. So the autonomic nervous system is part of your nervous system that's auto, self. You can't control it, okay? So you could see here from your brain and from your pons right here, that part of your brain, you have your vagus nerve, which is your cranial nerve 10. That has parasympathetic, meaning it's going to decrease heart rate. Now here, you have your sympathetic cardiac, and that will increase. So your sympathetic nervous system, that's your fight or flight. What's going to happen to your heart rate, cardiac output, stroke volume? Everything's going to be increased. Your vagus nerve, everything's going to be decreased, because parasympathetic is what? Feed and breed. So when you're eating, or you're a bit libidinous, or you're in love, your heart rate should what? Decrease. You should be relaxed. And you could see these things will fight each other, right? And that's where the balance of your autonomic nervous system comes in. Just know sympathetic, increase, parasympathetic, decrease. And who's part of your parasympathetic? Your cranial nerve 10, also known as your vagus nerve. And all of it originates in the pons. So if my patient has a basal skull fracture right here, how much trouble is he or she in? Lots. That's why I'm okay with you cracking your skull up here, but down here in the base of your skull and here in the back of your head, because this part here, your arbor vitae, your cerebellum, it controls blood pressure. So anyone wants to kill themselves today, don't shoot this part of your head. You're going to live. Shoot back here. Not saying to kill yourself. I'm just having dark humor on a very bright morning. And of course, all of these are reflexes. Baroreceptor. Baro is pressure. You have baroreceptors, and there are some in your carotid, which is the side of your neck. That's why if you're doing like a rear naked choke, you're not only choking somebody, but you're messing with these baroreceptors, and it can turn your blood pressure off. And that's why, not a good idea to be choking people out from behind. It's not a good thing. That's why when I, just like everybody, I love the fighting sports and I love MMA, but as a clinician, when I watch someone get into a rear naked choke, and I'm like, oh my God, oh my God, oh my God, because what will happen? The baroreceptors. So what are these things? Baro and chemoreceptors. Let's talk about just these two things, because they're directly related to the heart and blood pressure. So baroreceptors, think what? Blood pressure. They're to sense how much blood pressure. Is it increasing or decreasing? And chemoreceptors, they're going to sense oxygen, carbon dioxide, and the level of hydrogen ion, or acidity, or pH. It's the best way to put it. And hello, oxygen, carbon dioxide, and pH. That's arterial blood gas, which nurses have to be experts at. Okay. Endocrine, but nothing. We already talked about calcium, caffeine, nicotine, any exogenous, meaning drugs or things from the outside world, can also affect your heart. Anyone here coffee drinkers? Right? I used to be a massive coffee drinker and smoker. I couldn't, in my 20s and 30s, I couldn't get up without either one of the two. But because I found myself being a hypocrite, giving people medical advice when I don't even take the medical advice myself, I changed my ways over the years, and now I even quit drinking. And if anyone who knows me personally, I love drinking, but it's just not good, especially in your older years. is alcohol is really not good for you. Even though I always say, me and alcohol, we had a good run. It was delicious, but time to call it a day.
How about like stimulants?
Yeah, like anything that will increase your sympathetic, will increase your heart rate. Now the only natural and good thing that stimulates your heart rate is cardiovascular exercise. That's the only good thing. But exogenous chemicals like nicotine,
Ritalin or something
caffeine,
like that, like-
right, sugar,
Yeah.
it does a number, and you could see there the direct controls of the sympathetic nervous system to your heart rate and your cardiac output. You're going to make your heart work a lot harder than it should when it shouldn't. And if any, do you also wonder why so many people have anxiety states? They said something like 20 million people are on anti-anxiety meds. How's this, right? And again, I'm hopping on my soapbox again, but sorry, because there is data related to this. For years and years and years, I have avoided therapy and I'm high strung as it gets. I grew up in New York City. I'm a veteran, so that's more than high strung that you need, right? And also, I'm a very type A personality. You gotta talk to somebody because everyone has their own personality traits, and people in the healthcare industry are we wear our hearts on our sleeves, and to deal with the level of emotion of our jobs is. Did you guys ever wonder why I'm not a doctor anymore? Why would I walk away from? Especially, I was on the cusp of passing my boards. You know, I become a specialist. That's $300 an hour, man. That my salary jumps to hefty six figures. But why? It's such a high pressure job. I had a friend of mine. He's a cardiovascular surgeon. He just finished his training. He's 53 years old. He's already had 2 heart attacks. And it was really, so if dealing with all these exogenous things like caffeine, coffee, nicotine, right? And on top of dealing with stressors, it's going to do a number on your heart. So what do you think happened when I left the business? I started taking care of better of myself. I started sleeping better. I lowered the caffeine intake, quit smoking, did all these things. So what? I am the only Garais male without a heart attack, and I'm in my 50s. I don't think I'm going to have a heart attack anytime soon or anytime in the future. Because why? I'm removing things that will increase my sympathetic nervous system, and you could see here that it was a reflex, meaning to say is these things will happen whether you're conscious of them or not. I used to even get chest pain when I was a physician. Like every day I'd be like, wow, like my chest would hurt. And was it a surprise that I was in my early 30s and my blood pressure was 180 over 110? Standing heart rate was like 89, 90 something. I had a smoker's cough the majority of the year. I got bronchitis. I had chronic bronchitis as well on top of all of that. Ugh, it's awful. You're lining yourself up to what? And you see this term here, inotropic factors, contractility, caffeine, sugar. When I say sugar, excessive sugar, because if we take way too much intake, too much of a good thing becomes a bad thing. Positive inotropic factors, meaning what's it going to do? It's going to make your heart pump harder and faster. Okay. And then there's also other drugs that will do the exact opposite and other things. But those exogenous things, emotion and all of those things lead to it. Afterload, preload, I'm going to talk about that. No, I'm not going to talk about
So
that.
do they increase the heart's contractility, or do they?
Both.
Increases
heart rate, stroke volume, everything, because in order for you to increase your stroke volume, right? In order for you to pump more blood, don't you have to have a greater force of contractility to push out more blood?
Yeah.
right?
So
So
that's gonna
when-
wear out your heart. Like,
and it's going to wear your heart out, right? Like this, but if you exercise on a regular basis and
Mhm.
it stretches and then relaxes, stretches and relaxes, so that your heart's used to what? It doing that naturally. Did you guys ever wonder why little kids can run all day and their blood pressure doesn't get above 80? You ever, those of you who have children, you ever see kids? They'll run and play all day. Well, maybe not kids nowadays, but I try to let my children out as much as I can now, because actually my older kids now have vitamin D deficiencies. Because where are they? They're in the room right next to me all day, every day on their screens. They don't see the outside world. So I bought them bikes, I bought them everything, and it's now mandatory in my house. Okay, we're going to the park. Oh, it's 90 degrees out, Papa. And I'm like, I don't care. I want you to go run outside, not on the treadmill, inside, outside. I want you to get on that bike. My daughter's 13 years old, doesn't know how to ride a bike. So I bought, you know how cheap I am. I went on the Facebook market and some dude had some rusted bikes in his backyard. A day with some Rust-Oleum and some light sanding paper. And then I went to the thrift store and got some pieces of bikes and stuff like that. I bought 2 bikes, really nice bikes, mountain bikes for what, $50? And now it forces my kids to do what? Like they're dreading right now, me getting off this call, because right after this call, guess where they have to go? All go. I'm like, I goes, well, we're all going to my campus. I have to go fix my lab. Guess where they are? You're going to see them later, riding their stupid little bikes around the Stratford and Alexandria campus with the look on their face like, what am I doing this? And why? Because I'm doing this. I'm messing with their anatomy and physiology because I don't want to end up. Like, do you guys ever look in the mall and look at how fat kids are? And I was at the mall for the first time in a year. I was looking at how many people are obese, not just fat, but obese, as in can't touch their toes, can't run. And I was looking around and I'm like, why did I quit medicine? I could be making a fortune right now. You know, I should have went into cardiology. You'd be making a fortune right now. But don't want the stress, right? And I'm also to blame too. I'm eating Doritos, drinking beers, and not beers, but my thing now is Coke. I'm trying to get rid of anyone addicted to Coke here, Coca-Cola or soda. I'm trying to get that out of my life, and it's so hard. I quit drinking like in a week, and it was easy. I've been drinking all my life, drinking since I was 12, right? And I quit drinking, quit smoking like that. Took a couple weeks, did what I did. Well, I'm exaggerating about the smoking part, but I followed a regimen and I got rid of it. But man, to be honest, like if I'm in a bar or whatever, I'm walking around and I smell smoke, I get, I get thirsty, I get a little hungry for that cigarette, but then you just get away from it. But I really cannot live without Coca-Cola, and it's really a problem. I've reduced it considerably, but guys, I checked out some of that stuff. When you put Coke on in your toilet and stuff like that, you ever see those TikToks and memes on
those are
Facebook?
so disgusting.
Yeah, they're all true, and it's messed up.
Oh
And
my
I'm sitting there just drinking Coke like it's going out of style, and I'm like, but now I got it down to. I used to drink like a liter a day, and now I'm gotten it down to like maybe like a half a can or a can, but still like every day. And now I just ran out. And my wife refuses to get me more Coke because, she's like a health junkie, and my daughter too. My eldest is like, she only drinks water. And I'm like, what's wrong with you people? I go, don't you know how awesome Coke is? It's pure sugar. It's awesome. And I love it. But as you could see here, just going through this first part of cardiac, you can see how much trouble it causes. All righty. Let's now stop the recording.